Good evening, everyone. Friends, as you know, Chikungunya has been in current news due to its unusual manifestation and there were some outbreaks in some part of Maharashtra like Pune, Nagpur, Solapur, and also Mumbai. So, government of Maharashtra has also come into action to investigate this, and also as a caregiver, it is our duty also in view of this. In view of this, uh, in urgency, we have arranged a short we have arranged a webinar on short notice to discuss this with the pediatricians who are witnessing these unusual cases and also scientists from National Institute of Virology, Pune, who are also involved in ongoing investigations. So, first of all, I request our beloved President, Dr. Ram Gopal Chezara, sir, to have his opening remarks. Over to you, Ram, sir.
Thanks, Amol. Good evening, everyone. Welcome to another episode of Tips in Office Practice. As the title suggests, we always get tips from our experts. Since there is a sudden outbreaks in few parts of the Maharashtra, as Amol has already told about it, we decided to keep this topic of Chikungunya. Now, I welcome our moderator, Dr. Dhanya Dharampalan, and a special thanks to her for arranging the session on a short request. I welcome Dr. Anuradha Tripathi and Dr. B.V. Tandle, NIV from NIV Pune. They have also joined on a very short notice. So special thanks to them. Now I welcome our team MahaIP members and Vice President Dr. Atul Kulkarni sir, our EB member from Pune and ID specialist Dr. Pramod Kulkarni sir. And now whenever there is an involvement of joints, to get the Vijay on that, I welcome our Dr. Vijay Vishwanathan. I can't see him. Where are you, Vijay? Okay, special welcome to you. You are unmuted. Unmute yourself. You are muted.
Thank you. I hope I am of some help to this debate.
Yeah. So, welcome all. Amol, we can start the session. Yeah.
Thank you, Dr. Ram Gopal sir, for your remarks. Now, friends, as you all know, Dr. Dhanya Dharmapalan, she is today's moderator. She is ID specialist from Apollo Hospital, Navi Mumbai. So already Ram sir has already told about all the panelists, Dr. Atul Kulkarni sir, Dr. Pramod Kulkarni sir, then Dr. Vijay Vishwanathan sir, Dr. Anuradha Tripathi ma'am, and Dr. Balasaheb Tamble sir from NIV Pune. So I will now, without wasting time, I will request Dr. Dhanya Dharmapalan to take us further in this episode. Over to you, Dhanya.
Thank you very much. At the outset, a big thanks to you, Dr. Amol Pawar, for arranging this at such a short notice. And thank you, Dr. Ram Gopal Chejara, for supporting this, as well as all members of MahaIP. Thank you to our esteemed panelists who agreed at such a short notice to be part of this panel. What we will be doing is the first presentation will be given by Dr. Atul Kulkarni, followed by a panel discussion when I will introduce rest of the speakers. To introduce Dr. Atul Kulkarni, everybody knows him. So he's a senior consultant pediatrician and an ICU in charge at Ashwini Hospital in Solapur with a very vast experience in Chikungunya. And he's also the Vice President, West Zone of Indian Academy of Pediatrics. Inviting Dr. Atul Kulkarni to give us an overview of Chikungunya in children. Thank you.
Thank you, Dr. Dhanya. Good evening, our President, Dr. Ram Gopal, Secretary, Dr. Amol Pawar, and Dr. Tandre, Dr. Anuradha, and other faculty, Dr. Pramod, Dr. Vijay, and all the esteemed dignitaries on the virtual platform. The plan is I'm going to present to you presentation on chikungunya, basically overview, and few of the case presentations. And so I am sharing my presentation. Are you able to see the?
No.
Not yet.
Not yet. Okay. Are you able to see it?
Yes, sir. We can see the screen now.
Okay.
Yes.
Because short of time, I'll start with the presentation. Starting with the case, 2 months male child presented with a fever and irritability for 2 days. On examination, there was tachycardia, CRT was delayed, child was maintaining saturation, flushing was there. This was the child. You can see the child, my fingers of the child's abdomen. So flushing was there, and there was also CRT was also delayed. So looking at this picture, what comes to our mind? Fever, short duration, flushing. The first thing comes to our mind is the dengue fever. So systemic examination, respiratory, there was tachycardia and CVS, and child was irritable. AF was normal and Morozzo was normal. On investigation, child was showing hemoglobin 12 gram, total count 7,200, platelet count on the lower side, electrolytes were normal, CRP was raised, and blood culture was also sent in the view of high grade fever, 2 months old baby, and NS1 was done, NS1 is negative. So on 4th day, child, on the leg of the child, this type of lesion appeared. These are vesicular bullous lesions. And looking at this lesion, we sent the chikungunya PCR, and chikungunya PCR came positive. So this is a clinical clue for the diagnosis. One of the diagnoses is infants, they can get a vesicular bullous eruptions. So the test for chikungunya PCR came positive. Looking at the mother, she had similar history of fever for 1 day. She was having flushing, and you can see here red ear, and this is called as million ear sign. So nowadays, most of the time, looking at the mother, she is having pigmentation of face, especially over the nose, or redness of the face and on the ear. We can get some clue that baby, if comes with a high grade fever, maybe a chikungunya. So this baby had developed later on the crusting, and so this was a chikungunya. We had an epidemic in 2006, and that time we saw many of the cases. So just introduction about the virus. It is arthropod-borne virus. It was a tropical disease only initially, and now it is seen all over the world. Even though the mortality is very low, it is considered to be a significant health issue all over the world due to economic damage caused by human productivity, because in adults, they may have severe arthritis and disability also for a prolonged period of time. Name of this chikungunya is derived from Mokonde language. This is called Kungunyala. Become contorted, that is bent position or stooped posture due to joint pain, and this is the hallmark of the disease. Just historical aspect of the India. First outbreak was in 1964, second was in 1973, and there was a silent, disease was silent till 2006, and there was major epidemic broke up along with the Union Island epidemic, which was in 2005, and also in the southern part of India. Approximately 1.36 million people were affected, half of the Karnataka and 1/4 of the Maharashtra. We comes in the near Karnataka, so we were also badly affected. We used to see more than 150, 200 patients per day that time, that for months. Everybody was exhausted in 2006, seeing the chikungunya patients. Multiple epidemics after that were noted in India. So there was another epidemic 2014, 2015, 2016, 2017, and it's still going on. Last epidemic was in the Delhi 2 years back, and now in Pune, Solapur area, we are again getting increasing number of chikungunya patients. Chik virus is a highly cytopathic virus. It is alpha virus family from the togaviral family. It is single standard RNA virus. Today we are having NIV, Dr. Tandare and Anuradha madam. They are going to highlight, give more information of the about specificity of the virus and also the test, specific test, and is there any change in the virus. Transmission mainly by the main vectors is Aedes aegypti, same as that of the dengue mosquito. Aedes albopictus is another mosquito which can also transmit this virus, but Aedes aegypti is a better vector, highly susceptible to virus, prefers to live in close to the people, bites painlessly, and it bites several people in a short time of a single blood meal. So you many times you get more than 1 or 2 people in the family get affected by chikungunya in a short period of time. This is originate from Southeast Asia, but Aedes aegypti is a co-vector for dengue and chikungunya. This we have to again remember. So how transmission occurs? In the viruses, mosquito horizontal transmission occurs, that is the main cycle. It can cause the vertical transmission to the eggs, which represent persistence of infection under the harsh conditions. Transmission to the human beings can occur because of mosquito bite. Horizontal transmission not been reported in the human beings, but RNA virus remain in the detected in semen up to 30 days. Vertical transmission is been reported. We have seen neonatal chikungunya. In early pregnancy, if mother gets the infection, can cause miscarriage. No transmission through the breast milk. Blood products can transmit, but not the solid organ transplants. Pathogenesis. In short, after this mosquito bite, there occurs injected in this chikungunya virus inserted into dermis. Viral replication locally and connective tissue, epithelial cell, and fibroblast. The viremia mainly occurs through the monocytes responsible for dissemination in the blood. Mainly muscles, joints, and fibroblasts are targeted. So we get the arthralgia and sometimes chronic persistent arthritis or RA-like arthritis in the especially in the elderly. Coming to the clinical presentation, majority are symptomatic. Infective bite results in the acute chikungunya fever, approximately 95% of the cases, but sometimes in the adults or even adolescent children, you may get a fever lasting only for few hours, and after that you may get a joint pain and difficulty in walking and bent posture or this thing. The classical triad is fever, rash, and arthralgia. Like dengue, fever, rash, and headache. Here the fever, rash, and arthralgia. Arthralgia is 90 to 50 to 97%. Sudden onset febrile illness with arthralgia, myalgia, backache, headache, photophobia, and fatigue. Fever is a predominant symptoms. Usually fever lasts for 2 to 3 days, may last or up to 5 days. It has been reported up to 10 days, but in this epidemic, we are seeing the patients having prolonged fever for more than 14 days. Fever is usually high grade, poor response to antipyretics. Arthralgia, polyarthralgia, more than 10 joints are involved, bilateral symmetrical, mainly peripheral joints like ankle, wrist, and phalanges, large joints like elbows and knees. Axial skeleton can be affected in acute phases. Intense and disabling immobilization can occur. Typically, it is less in children, 30 to 50%, or even less in children. In many precedes with the fever, permanent destruction of joint is rare. Cutaneous manifestations, 50% of adult, there can you can get itching, edema of the face, patchy or diffuse rash, which lasts for 3 to 7 days. Generalized in adults, they get a morbilliform maculopapular rash, sparing the face. Flushing and erythema over the face is very common. in the adolescents, in pediatric age group, also in the adults. So here you can see the classical million ear sign, redness, flushing of the face. Then hyperpigmentation, central facial region predominantly involved in the nose. This is called a chick sign. So you can see a newborn 15 days old presenting with a black nose, and this disappeared after 15 days to 1 month. Even in the older adult or adolescents, or even in the geriatric age group, after chikungunya, you get black nose or pigmentation over the face. Erythema over the ear lobule, that is called as million ear sign. Erythema of stria in females. Then acrocyanosis you may get in the, especially in the infants. Superficial vesicular-bullous lesions in the infants, you can see this type of lesion. This was a adolescent girl. She had this type of vesicular-bullous lesion with a history of 1 day fever. 3rd day, this type of rash appeared. You can see these vesicular-bullous lesions. Purpuric or echomatic lesions can be seen. Then subepidermal bulla. This is another child, 3-4 months old baby. Lesions resembling 10 and non-healing ulcers. Non-healing ulcers are very common in adults, especially in the mouth. Non-healing ulcers. Hemorrhagic manifestations can be seen sometimes, multiple echomatic patches, but severe manifestations are less rare. You may get diarrhea, nausea, vomiting, abdominal pain in other like erythema, asthenia, congenital sufflation, cervical lymphadengus. You can see get the cervical lymphadengus. This is one of the differentiating point between the dengue and chikungunya. Facial puffiness. CNS. Initially, it was thought that it is usually is not serious illness. But after the epidemic from Reunion Islands and India in 2005, it has changed the perception. So you can get status epilepticus, complex seizures, encephalitis. Long-term neurological complications are, and usually after encephalitis, many of these children, they get long-term neurological complications. Polyarthritis and arthralgia. Persistent severe polyarthritis without signs of arthritis is the most prominent feature, associated with prolonged morning stiffness. Especially in the adult, they are not able to walk even for few months, or some adults, they had a problem for years also. Small giants are mainly involved, seen up to 60% of patients, but usually less in pediatric age group as compared with the adults. Acute phase less than 3 weeks. Subacute phase is 3 to 3 months, and chronic phase is more than 3 months. There can be chronic polyarthritis or which flares up of pre-existing arthritis. Response well to conventional DMARDs, that is anti-rheumatoid drugs. Hence, it is inflammatory iteration is more likely. Also, infiltrations with macrophages and monocytes. Specific polyinflammatory mediators like IL-6, IL-8 are also seen in the synovial fluids. Some rare manifestation or atypical manifestations. Hepatitis, nephritis, myocarditis have been reported. GBS, we have seen myocarditis. GBS, myelitis, cranial nerve palsy, neuropathy, meningoencephalitis, uveitis, retinitis in chronic phase of illness, alopecia. These are the all reported atypical manifestations. We have seen many of these complications. In neonates, there is insufficient time to maternal production of viral antibodies. So it was first described in La Union outbreak in 2005. Intrauterine transmission is highest when the mother are viremic in the week of preceding delivery. Usually you get a history before delivery, 3-4 days before delivery. If mother has high-grade fever and rash, and if mother delivers, there are highly chances that neonate may have transplacental transmission. Usually this baby is present 3 to 7 days after delivery. Manifestations: fever, refusal to feed, apnea, skin manifestations, bullous lesions, flushing. You can see a newborn, 7 days old newborn, just cord has fallen with flushing. Then hyperpigmentation. This baby presented with a status fever and convulsions on day 5, looking like a sepsis. So this newborn was admitted in NICU, treated like a sepsis. Child was on a ventilator. There was thrombocytopenia, initially treated with antibiotics. Cultures were negative. 10 days after, baby had persistent fever for 3-4 days. And when child was extubated, we saw this type of rash on the face. And we did chikungunya IgM. It came positive. Mother had a history of fever just before delivery. Her IgM was also positive. So it was transplacental encephalitis. And this baby is now is having major neurological problems. So most of the meningoencephalitis have prolonged neurological problems. Cerebral edema, hemorrhage can occur. Meningoencephalitis, this is the MRI of the same newborn, which was showing chikungunya-like encephalopathy. So what are the differentiating features between children and adult? Maculopapular rash is seen in both, usually on trunk. Pigmentary lesions are more in children, but now I think in this epidemic, in adults also they are getting pigmentary changes. Bullous lesions are especially seen in less than 6 months of age. Oral ulcers are common in adults. Purpura and hemorrhagic manifestations are seen and reported in newborn babies as compared to adults. Myalgia, arthralgia is there in children, but arthritis, arthralgia, systemic, symmetric, and more commonly affecting distal joints is seen in 87 to 99% of adults. Tenosynovitis, back pain, and myalgia. So, joint problem is more common in adults. In children, is usually short-lasting. Chronic joint manifestations are there in 5 to 10%, and arthralgia is persistent up to 1 year is seen in about 57% in adults. Headache, neurological signs like seizures, acute encephalopathy, encephalitis seen in about 10 to 30%. Headache is common in adults. Encephalopathy, Guillain-Barré syndrome is seen less than 1% of cases in adults. But this epidemic, since the Pune, they have reported many patients with a neuropathy and other neurological complications. Acute symptoms usually resolves between 7 to 10 days. Mortality previously considered to be rare, but seen in elderly, neonates, and immunocompromised. Some may have relapse of rheumatological symptoms months after acute illness of like polyarthritis or tenosynovitis. So distinguishing between the dengue and Zika is very important because there is same mosquito, similar clinical features, and circulating in the same area with co-infection. So Zika, dengue, and chikungunya, usually there is high fever. Zika usually you get a less fever as compared to dengue and chikungunya. Rash is common in Zika and chikungunya. You may get in dengue also typical rash. Conjunctivitis is common in Zika and sometimes you may get in chikungunya. Arthralgia very common in chikungunya and Zika also. Inflammatory arthritis is common in chikungunya. Myalgia more common in dengue. Headache common in dengue. Retroorbital common in dengue. Lymphadenopathy is common in Zika and chikungunya. Hemorrhage is common in dengue. Shock also in dengue fever. Leukopenia you get more in dengue fever. Lymphopenia is common in chikungunya. Thrombocytopenia classical in dengue fever, but mild to moderate thrombocytopenia you may get in chikungunya. CRP is elevated in Zika and chikungunya, and hematocrit is usually raised in case of dengue fever. So these are because the presentation is usually same. Lab diagnosis, non-specific hematological pointers like lymphopenia, hypocalcemia, thrombocytopenia severe is rare. CRP is usually raised. Increased levels of creatinine, hepatic enzymes, and CPK. Specific viral isolation. Today we have virologists from the NIV. They are going to enlighten on this test. Specific test, what we are doing is the RT-PCR, 100% sensitivity with 98% specificity, but should be done within 5 days. Immunochromatography assay, E1 monoclonal antibody detection. This is also highly sensitive and specific. Serological methods, ELISA for IgM and IgG. IgM from 5 days to 3 months, and IgG appears after 2 weeks. Plaque reduction neutralizing test can also be done, but this specificity of serological test is not high because there is cross reactivity between chikungunya and other arbovirus. Temporal sequence, like dengue, here we can get fever for 4-5 days, viremia for 5 to 7 days. Arthralgia, we start from the 2nd or 3rd day, may last for months. Myalgia for 4 to 5 days. Skin rash usually about the 3rd day. PCR detection in the first 5 days. IgM after 5 days, 5 to 6 days, and IgG after 14 days. So WHO criteria for surveillance. This is probable case which meets the clinical criteria. What are the clinical criteria? Acute onset fever, severe arthralgia or arthritis, not explained by other medical conditions. Possible case, patient is both clinical and epidemiological criteria. Epidemiology is the residing or having visited to epidemic area, having reported transmission within 15 days of onset of symptoms. Confirmed case is laboratory in irrespective of clinical or epidemiological criteria. In laboratory criteria, isolation of virus or RT-PCR or presence of IgM in acute or convalescence phase, or 4-fold rise of IgG. Treatment, non-specific, no specific viral therapy is there. So it is supportive care, rest and fluids and medications. Hospitalization is infrequently usually required, but high fever, sometimes children comes with convulsions, encephalitis, these are going the requires. Infants, older adults, immunocompromised children, patients, severe complications related to underlying medical conditions may have to hospitalize. So antipyretics and analgesics are usually used. Best is the paracetamol, usually sufficient and recommended. NSAID is used only when dengue is ruled out. Analgesia is inadequate with paracetamol. Co-infection with dengue and chikungunya virus can occur. So acute dengue infection needs to be excluded even if diagnosis of chikungunya infection is confirmed. So better to rule out dengue even though you are suspecting chikungunya. Try after 2 weeks you can try other NSAIDs, ibuprofen or naproxen, but no evidence that suggests superiority. Opioid analgesic usually we don't use in pediatric age group. Systemic corticosteroids and immunosuppressive medications, usually safety during acute infection is not established. Rash usually responds spontaneously. Between 1 month to post-acute infection, between 1 month to up to 3 months, you can continue with the NSAIDs. In adults, they use steroids. Additional, I think the Vijay is there. He is going to highlight on these drugs. Addition of some other medications like neuropathic pain, like pregabalin or gabapentin, and chronic disease beyond 3 months. Disease modifying anti-rheumatic drugs therapy involved. Vijay has to talk on this. Prevention, no vaccine is licensed in India. So how to protect yourself from chikungunya is the best thing, but very difficult. Mainly vector control and personal protection to prevent the mosquito bites. This is very important. So the prevention, you know how to control the vector is these are the various methods. During this year epidemic, what we have seen is the prolonged pyrexia. Some children, especially in the adolescents, they are presenting with a fever. After 1 to 2 days of fever, they have typical leg pain or bent up posture for 1 or 2 days. Then 2-3 days gap of fever, and after this, they have continued fever for. We have seen patients with the 14 days, 18 days fever without and leg pain. They are having very high grade fever, 103, 104 with rigors. Other investigations all are normal. and after 2 weeks, the fever is subsiding. So prolonged pyrexia is one of the important. Yesterday only, one child was referred to me. Child had a fever for 16 days. And child was admitted with he was on ceftriaxone for 9 days. CRP was raised, ESR was raised. No other. They have done blood culture. Then tropical PCR test was negative. They have done Vidal was borderline positive, so was treated. But when I saw the child, this was the picture of the child. You can see the pigmentation. So we sent the chikungunya IgM ELISA, which came positive. So this is a short presentation about chikungunya. Thank you very much.
Thank you very much, Dr. Atul Kulkarni. That was really very informative. And with all these clinical pictures, it was really very helpful for all to understand. So I shall move. We shall now start the panel discussion, and I shall welcome all the panelists. So Dr. Pramod Kulkarni has joined us. He's a well-known pediatric infectious disease consultant in Pune. We also have Dr. Vijay Vishwanathan, who is a pediatric rheumatologist from Navi Mumbai. And we are very honored to have among us two scientists from NIV ICMR Pune, Dr. Anuradha Tripathi.
Hello,
She
everybody.
is-
Good evening. Hello, everybody.
Good evening, ma'am.
Am I audible? No?
Yes. She is the scientist
Okay,
F, group
thank you.
leader of Dengue and Chikungunya department at ICMR NIV Pune. And her research focus is immunopathogenesis and immunogenetics associated with infections like dengue and chikungunya. We also have another eminent scientist, Dr. B.V. Tandale. He's also a senior scientist, scientist G and group leader, epidemiology group, and his main research interest is arboviral disease like dengue, chikungunya, Zika. So we are so fortunate to have both of you on this panel. So
Thank you.
to start with, I shall ask the question next to Dr. Pramod Kulkarni because Pune is a hot area and there's a lot of reports in the media. Everybody's talking about the outbreak in Pune. So Dr. Pramod Kulkarni, your inputs on what you're seeing in Pune, anything unusual?
Good evening, everybody. Uh, Basically, we started seeing the cases 2 months ago. In the month of August, July end, we started seeing cases of chikungunya. And over last month, end of August and first few weeks of September, it was so frequent and almost everybody has seen. On one group discussion on WhatsApp, academic discussion group, a query was put or a concern was expressed about the chikungunya, and it was just flooded with everybody giving his inputs. And according to those inputs, almost all these are experts. We have all the diagnostic facilities in the private labs of Pune, quite reliable. And the cumulative information which came at the end of one day discussion on this group came out to be a frequent site of chikungunya, very high number, unusual frequency of it. Secondly, the prolonged fever or the biphasic or even triphasic nature of the fever. Then the unusual number of complications we had seen. There were reports of almost 12 to 15 neurological involvement, then coagulopathy, few reports of shock needing inotropes as well, lung injury, coagulopathy, liver failure, HLH, and skin manifestations. And the young infants and neonates being reported having typical vesiculobullous rash and a sepsis-like picture. So all these things were expressed, and it was already reported in adults simultaneously by the adult ID specialist from Pune. We had heard of the similar report of bad chikungunya with complications from Nagpur just few weeks ago. 3 weeks ago, I had a conversation with my Mumbai friend, Dr. Vijay Yevle. He had noticed very sparse cases of chikungunya and none like this. So we thought this is something unusual. Dr. Rajesh Kulkarni has taken up compilation of these cases, the clinical data, which we will be proceeding further to process and publication scientifically. So let us look at the unusual things which we had here. So undue prolongation of the symptomatic phase. So it was more than 2 weeks, biphasic or triphasic fever, every time with significant joint manifestations. And in many of them, the inflammatory markers going high in the second phase, high in the second phase. And some of the kids having vasculopathy, which is very unusual, with capillary leak, as well as the known but uncommon complications of neurological involvement, which are very highly reported. We have similar reports from Baramati by Dr. Saurabh Mutha also, who has seen number of cases who were complicated like this. We have many reports from the neonatal units from Pune as well, having very frequent, complicated and serious chikungunya. So the concern is not about chikungunya. We never used to see so many number of cases and so many number of complications as well, requiring with high morbidity, requiring hospitalization. The hospitalization rate may be up to 30 to 35%, and the complication rate up to 5% of the total cases. And fortunately, we have not seen babies succumbing to chikungunya. So all these things are very unusual, and there was a concern from the pediatric fraternity. What's unusual about it? Is it the unusually high circulation of the same virus? Is it the different mutation which is causing high pathogenicity, or environmental changes? And n number of questions. I think we have experts here who will elaborate more on the possibilities. That's from my side.
Thank you so much. You mentioned about capillary leak. So the main differential point I understand between dengue and chikungunya is that dengue is associated more with hemoconcentration and capillary leak. So at the same time, Dr. Atul Kulkarni did mention that there could be co-circulation of dengue and chikungunya, and it's important to rule out dengue in such cases. So do you recall in those cases with capillary leak, was dengue ruled out?
Yes, that's a very valid question. But let me emphatically answer that. These days, every fever is tested within first 3 days for dengue with highly reliable NS1 to help us, which was performed in almost all the patients. Not only that, a follow-up to immunological, that is IgG, IgM, as well as NS1 was repeated in all these critical patients with ELISA, the reliable method, and there is no doubt dengue was reasonably excluded in all these cases.
Again, before I move on to Dr. Vijay Vishwanathan, I want to ask both of you this question that we also had a report of Zika from Pune that was, I think, in July. So, but we didn't hear much about Zika outbreak extensively later on. But understandably, Zika, dengue, and chikungunya transmission by the same mosquito. Did you hear about Zika much in Pune later after 2 cases was reported in the media?
Yes, of course, more than 2. There are almost 50 to 70 cases. I'm not sure, but in digits of 50s, there are reported cases. The reason for not further reporting, because the screening of patients at Zika, we all know it's not very morbidly symptomatic unless you have very high index of suspicion. And the target population being the pregnant women, in pediatric, usually the Zika is asymptomatic or mildly symptomatic. So probably it has escaped the screening test and the further workup also after suspicion. That's the reason I think Zika was not much sought after and reported in pediatrics.
Thank you. Dr. Vijay Vishwanathan, you are a pediatric rheumatologist, and surely you would be having cases of chikungunya referred to you, especially for the joint swelling, arthritis. Would you like to enlighten about the management as well as how do you clinically or through lab differentiate between the other form of arthritis, like say reactive arthritis, or say in a patient with rheumatoid arthritis, especially who is seronegative for rheumatoid arthritis? So please enlighten us about the inflammatory part of chikungunya.
So, very good evening to all the esteemed panelists. Like Dr. Pramod Kulkarni said that the outbreak has started a couple of months back, and Dr. Atul Kulkarni said referred to rheumatology only after 3 months. That's the standard disclaimer, which probably explains why I have not yet been referred a single kid with arthritis. My understanding of the whole issue is that children do behave reasonably well vis-a-vis the joint symptoms as compared to adults. And there are enough papers which talk about low interleukin 17 levels, etc., in the pediatric age group as against the adults who are at a high risk for joint complaints. Now, the way I understand or I remember reading chikungunya was to the general practicing pediatrician. To me, chikungunya looks like Kawasaki disease. The bloods will behave like lupus, so lymphopenia, leukopenia, thrombocytopenia, etc. And probably behaves like COVID is what I am thinking, hearing the stories from Pune and Solapur. Commonalities being obviously, why do I say it looks like Kawasaki? Especially the infantile chikungunyas will have fever with irritability. In KD, it's because of the aseptic meningitis. In chikungunya, you would assume that it's because of probably CNS involvement or arthritis or significant arthralgia, which makes the kid more irritable. Edema, conjunctivitis, pharyngeal inflammation, all look, and the rash looks very, very like Kawasaki disease. The unique thing that Dr. Atul has pointed, which is enough documented in literature, is the vesiculobullous lesions, which rules out KD and gets in chikungunya into the picture. Now, like you have incomplete KD, you would have incomplete presenting chikungunyas with who come to the hospital with joint pains, fever, rash, but eventually end up having organ dysfunction. And then Dr. Pramod Kulkarni talked about the really atypical manifestations of chikungunya, septic shock syndrome, which would mimic something like an MISC in my eyes. And there's a nice paper in clinical rheumatology from Paraguay, which says, should we be calling it as MISC in chikungunya now, where they talk about the full spectrum, GI, diarrhea, HLH, vasculitis, coronary involvement, myocardial dysfunction, CNS, etc. So, cut the story short, I think we need to keep our antennae open, and unfortunately published evidence, it's very easy to diagnose chikungunya from what we have seen. We anticipate that this is a child who may worsen, is probably what's going to happen. And let's all remember that for want of evidence, what saved quite a few lives in COVID was dexamethasone in a low dose initially. If this outbreak spreads across Maharashtra, the logical thing would probably be to start collecting all these cases, send them to NIV, get the scientists to give us inflammatory interferon signatures. That's probably the best way to identify which signature correlates with which clinical phenotype. Once we are aware of this, and there are enough papers about the inflammatory markers and the cytokine signatures that might help us wade our way through as far as the therapy is concerned. Sorry for the long answer.
Thank you. Is there a specific NACID? Dr. Atul Kulkarni mentioned that you must rule out dengue, very important point, before you give anything beyond paracetamol. Do you advise any specific NACID or for the chronic arthritis or?
So like I said, I haven't yet seen a bad arthritis yet.
Okay.
Most of the kids that I've been hearing do respond to paracetamol. But beyond the second week, you would assume that the virus has come and left the body. So it makes practical sense. You may start using a disease-modifying not exactly a DMARD, but an NSAID like an ibuprofen or a naproxen. A word of caution is please document a CBC, a normal SGPT, a creatinine, and a urine protein creatinine ratio. You do not want to aggravate the organ involvement which the virus would have already caused. The low dose steroids plus or with or without the DMARDs would probably come at the chronic stage of the disease where kids can behave, or less reported. It's more in the adults that they may behave like a enthesitis or a bursitis or a rheumatoid factor positive arthritis, a spondyloarthritis, a psoriatic arthritis, etc. I guess the numbers that we would be encountering with chronic arthritis in children would be less. My only concern is the acute severe presentations in the PICU vis-a-vis CNS, encephalitis, neuropathy, vesiculobullous lesions. Those are the ones which are scaring me. And for want of evidence and a bit of a reluctance to use steroids, I might be open with the idea of using something like an IVIG upfront when it comes to such nasty presentations, and then consider steroids if need be. Being very, very selective and choosy in giving the steroids.
Thank you. Dr. Anuradha Tripathi, I would like you to give your inputs about this outbreak. You have been involved with the research since more than a decade. So if you can.
Yes, thank you. Actually, at NIV, we have a panel where the suspected cases, we test them for dengue, chikungunya, and Zika. For chikungunya, it is quite straightforward because IgM and PCR they follow each other. PCR followed by IgM. In fact, we have been seeing IgM coming after 2 to 3 days. So that's why, unlike dengue, even if we don't do PCR, then also we don't miss any case. So that's the most important thing as far as chikungunya is concerned. So we are lucky that way because every lab will not have the capacity to carry out PCR. So IgM is the gold standard. We don't miss any case of chikungunya. And now coming to this year, so in 2024, I'll just take the start from the months of June, because that is the time when monsoon starts in Pune. From June to September 15, we have tested around 3208 clinical suspected cases of chikungunya, and we have found that 1004 more than 1000 cases positive for chikungunya. So that means it is 31.3% which are positive. Whereas compared to 2023, we had tested 2,376 suspected samples for chikungunya. Out of them, 440 were positive. So the percentage was 18%. When you look at the percentage, it is maybe 18 and 31. But when you look at the number of positivity actually, so it is increased from 440 to 1004. So that means there is an increase of 200 times. Is it? Yeah. So 2 times increase. So that's quite alarming. So we can definitely say that there is massive outbreak of chikungunya. Similarly, we compared for dengue also. So last time we saw that 38% were positive for dengue, and this year it is 27.9. So we cannot say that there is no dengue. In fact, in the early months of June, we are getting a rise in the dengue number of cases. Suddenly, from end of July, we could see there is an increase in chikungunya case. So that is the thing. One thing. So, and then we got some clinical samples, CSF samples from clinicians indicating that there are encephalitis cases. So we have carried out full genome sequencing from some paired CSF and also plasma samples. But definitely we need to do more number of samples to tell what is really happening, because the population, affected population is quite a lot. So doing 3-4 samples, we should not be talking on the mutation, all these things. but definitely we have carried out the full genome sequencing and the phylogenetic analysis. So we found that the circulating virus belongs to Indian Ocean lineage of Exa genotype of Chikungunya virus, and it is clustering with the earlier predominantly circulating strains in Pune, outside Pune, and also in India through 2020 to 24. So this indicates that the strain is not different. So we are carrying out now amino acid changes, but just we're looking at it, I do not see any major changes, but we have to do more number of cases to tell anything about amino acid change. But at least we can talk the strain is the same. It belongs to Exa and Indian. This is Indian Ocean lineage. And actually, I like the way Dr. Kulkarni presented. Quite a lot of pathogenesis, immunopathogenesis is covered. So in fact, and also Dr. Viswanathan, he talked about the cytokines, all these things. Actually, three of my PhD students have worked on innate immune response in chikungunya, but all my patients are adult. I have not worked with pediatric cases. So we could see that that's very interesting data we have got. Actually, I have been collaborating with Dr. Mohini Gano from Sanjeevan Hospital since 2007. So I mean, it's quite many years. So so that's why we get really very follow up of the same patient, and we could see that. Involvement of NK cells. Now that he was talking about pro-inflammatory cytokine, anti-inflammatory cytokine, TH17, I think Dr. Kulkarni talked about TS17. Yes, definitely TS17 involvement is there. So we could see TS17 means T regulatory cells. We could see that T regulatory cells have a prognostic value in chikungunya outcome. Prognostic outcome, and we could see also the acutely infected chikungunya patients who recover. They have their NK cells are numbers are very high, and they are also functional. And in case of the chronic chikungunya patients, we could see the NK cell frequency, that is the percentage, were quite low, and they were not functional. So we could pinpointly find out that these NK cells are the culprit, or they could be taken as the biomarker for recovery. If NK cells are functional, the chikungunya infected individuals, they go for recovery. In fact, we found like, I don't know whether I'm becoming more basic. It's okay if I talk that way.
Sure.
So
Please continue, ma'am.
Okay, so we looked at NK cell activatory receptors and also NK cell inhibitory receptor. In fact, but before I go to these detailed NK cell studies, I'll tell you how we had categorized the clinical categorization of the patients we had done. Like, with Dr. Ganu and Dr. Ashok Ganu, her husband. So, so we could see that 0 to 14 days was taken as acute phase of illness, and 14 days to 3 months, it was taken as prolonged chick period. And after 3 months, if the patient is still symptomatic, we call it as chronic. And at 3 months, if there is no symptom and everything, there is remission, so we call recovered individuals. So it was very nicely put, and we could see that all our clinical findings, they very well correlated with our lab findings. So we could see that in case of the chronic chikungunya infected patients, or later we call them at PCCA, post chikungunya chronic arthritis, and we also ruled out arthritis in them by looking at RA factor, anti-CCP antibody, and citric acid. So all these things we ruled out. So we could see that when we purified the NK cells of the chronic chikungunya infected patients and then treated them with NK inhibitory receptor, antibody to NK inhibitory receptors, the NK cells became functional. So this is how we have identified that the chronic chikungunya patients, they have impaired innate immune response. So if only the innate immune response is robust, they will develop a robust adaptive immune response, and their NK cells will become functional, and they also will secrete interferon gamma, which is an antiviral cytokine, which may lead to recovery. So this is how we have carried out these immunopathogenesis studies, and definitely we'll be interested to see what is happening in the pediatric group.
Thank you very much, ma'am. I also request Dr. B.V. Tandale. Sir, can you please give your inputs?
Good evening. I'm Dr. B. Pandey. I'm actually MD in preventive social medicine. Am I audible?
Yes, yes.
Yeah. So I have been in NIV for last 20 years now, and I have been involved in the chikungunya outbreaks since 2006, when most of these outbreaks happened in Karnataka, Andhra, and Maharashtra. I had been to field investigations, and I'll share some experience that I had during this earlier outbreaks. So the most of these earlier cases and outbreaks happened in rural areas, and attack rates were so high that 40–50% of the population getting affected in village, and almost in a family of 3 or 3 to 5, 2–3 people getting affected. So even physicians were not aware in early times of outbreaks and response, that they were thinking of there is something that respiratory virus or related illness is causing this kind of outbreak. And there was a lot of confusion how it is. And this was the first African genotype getting reported, although this was circulating in various parts of Africa earlier. This was getting introduced in India, in Karnataka, and then to Andhra, and then Maharashtra. Another important aspect is that during outbreaks and chikungunya, such as presented by Dr. Kulkarni also, that children are presenting with mild manifestations. So usually the arthralgia, arthritis component is not that severe as is in adults. So during the further investigations in Pune and Ahmedabad, we had many patients, especially elderly with comorbidities, presenting with multi-organ involvement, including hepatorenal dysfunction, deranged hepatic and renal functions. There were chills, very important aspect that I think somewhere discussed by Dr. Kulkarni in pediatric patients, was very prominent in these outbreaks. And we need to really think of chills as one of the common inquiry when we are inquiring the chikungunya patients. And that is why it is most of the time confused with malaria and other presentations that would be related to this. Another thing is that hepatic involvement is very common, and we need to, as is in dengue, so we have to be very careful with hepatic profile and investigations. About unusual features. Now, this is being talked about in Pune in last few weeks, that there is a lot of infection increase happening in last 2–3 months. But what we are worried about is the severe disease that is getting reported. But let me tell you that even during the Ahmedabad and Pune outbreaks, and Anuradha has been part of that earlier studies we did in outbreak situation. So we had 3 groups of patients studied: the chikungunya with systemic manifestations, classical chikungunya, and one asymptomatic. Some of them, family members and neighbors, were sampled. They had some asymptomatic infection. So we compared these 3 groups of patients and seen immunological profile for them. And the paper is already published. One of the papers that I authored as a first author in 2009 about the same in clinical features is published in Journal of Clinical Virology. And these are all presentations, and whatever we are getting, there will be some variation, clinical variation we expect in individual patient response. But definitely most of these atypical manifestations have been reported already in literature. Why we are concerned now is that there is a lot of infection, outbreak cases are increasing. So the proportion of cases, maybe that we don't know how many are there in community, how many are actually consulting. But one important aspect that Dr. Atul Kulkarni also said, most of these infections are symptomatic. I'll say more than 95%. So asymptomatic infection is though low. We know that the other infections are viral, dengue, maybe there is asymptomatic proportion quite a lot. So we need to take care of maybe the patient's manifestations and symptomatic relief. That is the physician's job. But as a epidemiologist and public health expert, I've been involved now in the state RRT with Dr. Anuradha, and we are discussing with the state and corporation health departments. We are actually getting the data to analyze for last few months and understand how that increase happened, and how can we, as a public health activity, control that issue better. Thank you.
Thank you very much for the wonderful work that is being done at NIV. And this is assuring to know that it's probably not the virus that has mutated, it's the large proportion of cases, and that's why percentage-wise complications are also seen more. And of course, as Dr. Tripathi also talked about, the work is still ongoing, but this information is also very useful for us. Thank you. So shall I take any questions from the chat? If there are any, if the organizers can let me know if there are questions in the chat. While we await for the questions, to our scientists from NIV, we talked of Zika outbreak in Pune 2 months back. Is there any particular reason why one infection attains an epidemic proportion? Zika, again transmitted by the same mosquito, we didn't hear so much as chikungunya. And what about your experience with Zika?
Actually, before Zika, correct. I think Dr. Who said? Dr. Kulkarni said, as he said, I think Zika was always there. We were never testing it. That's the thing I'll say. And because now testing system is better. Testing and most of us, like supposing we have now a trial place where we do testing for dengue, Zika. So we come to know it is Zika PCR positive. And I was going through the clinical manifestations. So basically Zika clinical manifestations are milder than Zika and also dengue. So that is one thing I'll say. Zika was always there. Luckily, we have not yet come across any microcephaly. That's the best thing about Zika in India. That is there. And when coming to this surge in chikungunya, I like to say this way. Since last 4-5 years, we were seeing dengue more. Dengue proportion was more. And we know that dengue has got 4 serotypes. And one person gets infected with one serotype, he gets lifelong immunity against that. And the immunity against the other serotype for a temporary period. So maybe it is the herd immunity. That is why dengue didn't come this time. This time we have got chikungunya. So that we can see. And coming to the severity of these things, I think one should look at the demographic data to know, and the comorbid condition, demographic data. That will be very interesting to rule out. We may get some definitely information from those things.
Okay, thank you. So I shall invite final comments from each of the panelists, starting from Dr. Atul Kulkarni. Thank you very much for setting the stage for this panel with your wonderful presentation. I can see Dr. Vishnu Biradar has just raised his hand. Shall I take?
Dr. Danya,
yeah.
We can invite the any questions from the audience. So Pallavi ma'am.
Yes.
Yes, sir. Yes, sir.
Please unmute others.
Yes, sir. Done. They can unmute themselves.
Can I ask one question, sir?
Yes,
I am Srinivasan from Pondicherry.
Okay, Srinivasan, sir, yes, please.
Yeah. Because we had seen a child, a newborn child, with rashes and myocarditis and died within 2 days. And subsequently only we got the report that it is chikungunya. And it was published also in Indian Pediatric, the case report. Have you come across any neonatal morbid trend from?
Sir, we have seen, I have seen 2-3 attended section. Mother had the chikungunya and there was muconephrid lacquer.
Exactly. That
and
is how we
baby-
thought of the chikungunya. Yes.
baby delivered with a heart rate of 200, sudden hepatomegaly, and within few hours expired. And this was during 2006 epidemic, which started that time. And at that time, we are not aware, and we are not having the PCR test also was not available at that time. So, but this was classically correlated with the, and myocarditis is well known in the neonatal age group or transplacental passage with encephalitis, myocarditis, or like a cytochrome MISC like syndrome, like can manifest like this in chikungunya also. Now the Paraguay report is also saying as like a 2 months baby presenting like MISC, which turned out to be chikungunya.
Thank you, sir.
Yeah.
Okay. Can I ask a question?
Vishnu Biradar? Yeah, please.
So this was regarding a baby which is 14-month-old. Dr. Atul Kulkarni knows about the patient. So this child had a hepatitis and chikungunya PCR positive, and he went on to develop the acute liver failure. And we couldn't establish any other diagnosis, including all the genetic tests of acute liver failure and all other infective things were negative. So the question is, now, can we do a chikungunya PCR or a stain on a liver specimen which we have removed to prove that it is chikungunya related? Because the biopsy itself is acute massive necrosis of the liver.
Okay, I shall ask this question to if any NIV esteemed science panelists can answer this. Dr. Tripathi.
Yes. I know this can be done, but one thing I'll tell you, mostly I think by the time the patient has come to that stage, the disease manifestation is immune mediated. So, so we really wonder whether we'll get any chikungunya RNA virus there or not. Because as far as chickpea RNA is concerned, we see maximum up to 10 to 12 days, even in the plasma.
Yeah. But this was in the liver tissue. Can we do something?
That is why if you want, we can do. But because the disease is immune mediated, all the other complications must be happening because of the immune complex or other host factors. If you want, we can do like we can see, we are seeing in CSF RNA, chikungunya virus RNA, we can see.
Okay. Okay, then I will connect you personally. Thank you.
Yeah, so I would like to add that in Ahmedabad, what we are seeing.
Andrei sir is telling something.
Yeah, so in Ahmedabad, what we see is there are some elderlies with comorbid conditions, and the viremia was detectable up to 21 days. So I have seen some patients in earlier episode. In current episode also there are some patients that those are elderly with comorbidities in Pune. One of our scientists in NIV himself suffered with, and he is now recovered and out of hospital. But his viremia was there up to 20 days plus. So it is possible that, and we should try. Thank you.
Okay. Dr. Sanjay Nathu next, please.
Yeah, thank you, Dr. Danya. So an excellent interaction about chikungunya. I wanted to ask a question. Just like dengue has 4 serotypes and one serotype infection gives a lifelong immunity, what is the situation with chikungunya? Is it expected to give a lifelong immunity, or a person can get a repeat infection?
Would anyone like to answer? Yes.
It's a very important question. Actually, we don't have any vaccine now. So very difficult to answer this question. Vaccine means in 2023 November, US Valcova have formulated a vaccine, Chick, which is FDA approved, which was FDA approved on a fast track basis, and it is not yet being used in all countries. So only when we have a vaccine, we can come to know, like, whether IgG is protective or not. So, but as such, in our observation, we see that the same person is not getting reinfection again and again. But we need to do more studies to talk about this thing, whether lifelong immunity or not.
Thank you.
Vaccine will give us the
Thank
answer.
you. Thank you.
Hello.
Dr. Surendranath, please.
Yeah, good evening, madam. It is a wonderful discussion. I have a query. Do we see the complications of chikungunya even in asymptomatic infants who are exposed to chikungunya? Or is it necessary that they should have the clinical presentation for having complications like myocarditis or any other serious complications? Are we seeing any cases like that?
So asymptomatic means without fever and
Yeah,
RAF
yeah.
is what you're meaning.
Yeah.
Dr. Atul
Like what we
Kulkarni.
saw, Miss C.
Yeah.
Usually fever at least have usually at least 1 day. Some patients may have only few hours of fever also. So in adults they are reported 5% of cases, 3 to 5% without fever they are presented with arthritis. But I really don't know whether they are going to.
Yesterday we saw one case with a huge cardiomegaly. The child did not have any problem 2 days ago. I mean, absolutely sudden onset of cardiomyopathy or cardiac failure. Can we see an asymptomatic?
So there are many other viruses which can cause myocarditis. So I think that they also should be ruled out because usually it is symptomatic disease.
Okay. Dr. Yevlis, sir?
Yeah, I'm sorry I had to leave the meeting in between, but I just heard Dr. Vishnu asking about the hepatic failure and the child suffering liver damage. How common is hepatic involvement leading to hepatic necrosis, etc., immune-mediated though? Is it really known in chikungunya? I mean, I don't know if Atul presented anything, but that is my question. And then, did this child receive some non-allopathic Ayurvedic kada bida medicine which led to hepatic damage?
No. This child had a chikungunya PCR positive when he presented. He was having hepatitis, and then slowly, over a period of 1 week, he started developing the ALS. And when the PPNR goes more than 10, chikungunya PCR is
No, I agree.
in the first
Chikungunya
step.
PCR was positive, but how common is hepatic failure and hepatic necrosis in chikungunya?
Yeah,
That
we
is my
did not
question.
came across any patient in the literature, or we spoke to many people, including Dr. Atul Kulkarni and others. But the hepatic involvement was there, but no patient was reported to be having acute liver failure. And that is what we are thinking about doing some testing on the samples, the liver which we have resected.
So it's just a conjecture. We do not know whether that hepatic failure can be attributed to chikungunya.
Because no other viruses were positive, and all metabolic tests, and including the whole exon with mitochondrial, is negative.
Okay. Dr. Bhavesh Mithya?
So this question is related to possibly an adult patient, because we don't see in children the chronic chikungunya presenting with the arthritis, arthralgia, debilitating conditions. So Dr. Anuradha Tripathi madam did mention about the NK cells function in the chronic patients. So they have inactivated NK cells, and then that she could even prove by doing the antibody against the inhibitors, and she can prove that in the lab that the NK cells were activated. So does it have any implication in a clinical medicine that can we predict who adult patient are at risk of getting into chronicity, or someone who is going to be only in acute phase? Do you have any clinical or a laboratory marker to predict or prognosticate in adult patients?
Dr. Anuradha Tripathi, ma'am.
I think she is muted.
Please unmute, ma'am.
I think she is busy. Her video is off.
We can circle back to her.
Sure.
She's there. She's there.
Okay.
Ma'am, please unmute. Ma'am. Yes.
Hello. I'm very sorry. Actually, I was coughing such a lot, so I went out. I missed your question. Could you please repeat once more?
Sir, please.
The question was that you had beautifully proven that the different immune responses in an adult chikungunya patient who are having a chronicity, they have a different NK cell function, which you could prove by giving the antibodies against the inhibitors, and you could prove that it's now activated. So can we have this the immune response as a clinical marker or a laboratory marker in an adult patient? Can we have some prognostication that someone is going to go into chronicity versus someone is not going to go into chronicity by using the LK cell functioning at the beginning of the illness?
That's a very good thing. Actually, for this is a very good idea. In fact, if you decide a set of patients like acute, we follow up a set of acute patients and who go to recovery and acute patient who go to chronicity. Sequentially follow up. No, not many a times. We know acute is for 15 days and chronicity starts at 3 months. Then if you do this NK cell percentages and functionality at the beginning of in the acute patients and in the chronic, we can definitely do this study. We need a good set of patients. That will be really interesting. It will be good because what mostly we have done, they are the follow-up patients are not they are not the same. It is a group of acute patients, group of chronic patients. If you follow up really, then the data will give some. We can talk about biomarker that way. That's a very good
Okay.
idea.
Okay. Thank you.
Dr. Akhilesh Kalawate from Shegaon, Periphery. Akhilesh?
Yes. Good day,
Please
sir.
ask your
My question is, are there any different strains of chikungunya? And if they are, the area-wise strains can be there. Can we differentiate between this Asian strain or Indian strain or African strain?
Atul sir?
Yes. Can I answer that?
Yes.
Yes.
Please go
Yes,
ahead.
actually, yes, we can do when you do the full genome sequencing, and then after carrying out the full genome sequencing, which match them with different genotypes, different isolates of different genotype, then we come to know where our virus goes. But since last 2007, that massive outbreak, Exa strain, East Central South African strain is circulating in India, and currently also this is of in Indian Ocean lineage, which is the part of Exa, is circulating in India. We can definitely find it out by doing the full genome sequencing from the clinical material of the infected patients.
Right.
Thank you. Dr. Deepa Firke.
Deepa ma'am.
Yeah. In Miraj also, we have got many cases typical of viral prodrome and coming with myocarditis and encephalitis. Unfortunately, we didn't send chikungunya in those patients. We had these myocarditis patients we had treated with IVIG, and one of them succumbed. So I just wanted to know that in case if they present with this myocarditis, what's the role of IV? As we already have discussed that it's an immune reaction. So if IVIG has to be given when and how much, whether like the same like an MIC case or it's different.
Dr. Vijay Vishwanathan, do you want to answer that?
Yes and no both, because I am almost sticking my neck out and saying that if it comes or presents as an MIC story, which is like an acute emergency in the PICU, 1 or 2 days history of fever, and the child comes with a shock with or without the skin lesions, I would probably straight away give IVIG. But the only caveat is we have learned from MIC that IVIG itself could precipitate a hypotension. So that little bit of the steroid cushion that I always like. And again, we will be entering 2 mg ki, 10 mg ki, 30 mg, and the ID people will not like me, getting into infectious territory. So I would think that a logical way is if the child has an atypical manifestation, whether it is an encephalitis, whether it is a neuropathy, whether it is a severe myocarditis, whether it is fulminant hepatitis, IVIG is not going to harm. Even a bad vesiculobullous presentation, like Dr. Kulkarni mentioned, TENS, I think there are enough case reports. Unfortunately, there are no guidelines which document that these are situations you have to use IVIG, but I would probably treat it like an MISC, but maybe keep, even in a bad for bacterial sepsis, you do throw in a little bit of hydrocortisone. And the only thing is, if it happens in the second, third week, I will be more confident about thinking of steroids. But in that first week of illness, give IVIG. 2 gram per kg is probably what you will be looking at. No half measures. No 1 gram per kg, 1 gram per kg. And if you think the child is hypotensive, you would still continue to give that little bit of steroids to stabilize the blood pressure. Then you go ahead with IVIG and then take a call how the child responds. And the same markers, I guess, CRP, ESRs, counts, N-terminal pro-BNP, etc. would probably come handy.
Okay, sir. Thank you, sir.
We'll take 2 more questions because it's already very late. Dr. Aarti Patil and followed by Dr. Madhvi Ingle had her hand raised. So
Yes.
Dr. Aarti Patil.
Good evening, everyone. One patient of mine, he is around 10-year or 11-year-old. In the second week, he had lots of like polyarthralgia and arthritis, unable to attend the school or write anything. So as per the protocol, like paracetamol did not work. So he was put on naproxen, but still it's not helping him. So how do we proceed in such children like who are not able to do any perform regular activities also and no relief with the NSAIDs also?
Dr. Vijay Vishwanathan. Yes.
So I would probably think that this is entering the third week of illness where you would assume that the virus has come and left the body. Now that is a again tailor-made situation. You would assume that there is more immunological issues than actual viremia. And I may think of steroid, but if it's an older kid, you might try an opioid like a tramadol, etc., to see if that helps, because there have been some reports where tramadol or codeine-based preparations do help in reducing the pain. That will buy you 1 week more of time, and beyond 4 weeks, I am reasonably comfortable to start a low dose of oral prednisolone for about a week or 2, and there are enough Brazilian, French recommendations where they talk about low dose prednisolone for 4 to 8 weeks. Beyond 8 weeks, if the problem still persists, then obviously you need to re-evaluate whether it is plain chikungunya which is persisting or it has just unfolded a rheumatoid factor positive arthritis, which is a very well-known entity vis-a-vis chikungunya. So there's a lot of familiarities or similarities with chikungunya with RF positive JIA, and the 10-year-old is the right age for developing JIA. So answer to your question is try out tramadol. 1 week later, throw in a little bit of steroids and keep checking the renal function test for me, because naproxen given chronically could end up with a chronic kidney disease, etc., which you don't want.
And can refer to pediatric rheumatologist, right?
Possibly, yes.
Yeah,
Yes.
I did that definitely. Like I referred to a pediatric dermatologist, but then he was
Rheumatologist.
started on rheumatologist, and he was started on disease modifying drugs in second week itself.
Okay. That's
So that was one thing which was like from this discussion, I felt like I should now rectify.
it's one of those things. Hydroxychloroquine, again, as I said, no, looks like KD, bloods like lupus, behaves like COVID. HCQS was the first drug which was tried in coronavirus, only to be thrown out of the window. As a rheumatologist who gives HCQS on a day-to-day basis, I know that it really starts to work after 4 to 6 weeks of daily intake. How does I'm assuming that the DMARD that you may have started is HCQS. Is it HCQS or is it something else? Methotrexate?
No, it
Sorry?
was not HCQS. It was not HCQS.
What drug was it? What did you start?
No. The rheumatologist had started. It was rofecoxib.
So that's an NSAID. It's not a disease-modifying drug.
Okay. So
I think if you are giving naproxen and more NSAIDs, just keep a watch on the LFT and RFT, and I guess 1 week later, I might be tempted to give a low dose of steroid and hope that it's a child. He may just get better with a 2 to 3 week short course of oral Visolon.
No, sir. As a pediatrician, I just continued
Doctor,
with NSAIDs, with naproxen. Okay, thank you.
thank you. And we'll just take a last question so that we can end this session. Dr. Madhvi Ingle.
Good evening, everyone. Actually, my question, there are two questions. First question is again pertaining to the encephalitis or other presentation like illnesses. My question is, do we have to have a rash? And if the child has reached to a tertiary care hospital in a later stage when we are not very sure whether the rash was really of similar to chikungunya, to what extent are we justified in giving either immunoglobulin when the patient's condition is bad and we are not able to find out what is the source of encephalitis, or as Dr. Biradar said, what is the course of hepatitis, what is the cause of hepatitis?
Dr.
So
Atul Kulkarni, would you like to answer this? Or
Rash,
Dr. Pramod Kulkarni one.
yeah, rash is not must in every cases. You may get it may be transient, it may be just flushing, or what we call as erythroderma can be there for 1 day or two, and that will disappear. That can disappear. So it is not mandatory, because after 3-4 days, rash may disappear also. So at the time patient reaches to you on 6th or 7th day, child may not have rash also. But the typical history, you have to ask high fever and bent up joint, especially in older children. But in infants, it is very difficult to get the. You may have extreme irritability and a fever.
yes.
This can be one of the things. And transient rash you can ask. And any other member in the family has already affected. That is another clue. 2-3 maybe, because many a times you get 2-3 patients in the one family same time.
And in such cases, we have to prove a diagnosis and then only go ahead,
But
or
there is
because it's
no
a
specific treatment for this. We are going to treat encephalitis as a supportive care, and also no specific drug we are going to use. Only immunoglobulin, yes, it is immune mediated, that we can use. Means if there is a myocarditis or encephalitis, I don't know. We routinely use IVIG for acute infection.
okay.
Yeah.
And
To
my
take on
second
the
question,
message, I will say these days, any case of acute encephalitis syndrome, you better work up, keep chikungunya in your mind, and do IgM, irrespective of the clinical manifestation. IgM and CSF for IgM as well as PCR. That should be the right way going ahead with encephalitis.
Yes, I think NIV is already doing the chikungunya in encephalitis panel, sir, because I have seen few reports, they have already done this one. But one question for Anuradha madam or Tandale sir, they have said IgM for the whether card test is equally sensitive, because many of the patient we don't get this card test negative, but ELISA definitely it is a better test. But how much sensitivity for the card test? Because classical chikungunya we get an IgM negative on card test.
I cannot comment on the card test, but definitely the IgM ELISA test is the gold standard.
Okay.
sir, are there any specific MRI findings the way we have for HSV or JE encephalitis? So is there anything related to chikungunya encephalitis, any certain part of the cortex or somewhere it is affected, so that we can correlate pending the reports, or if not possible to send the reports, are there any specific MRI findings or?
No, there are no specific and uniform imaging changes suggestive of particularly chikungunya have been reported. There is wide variety of clinical syndrome, neurological, as well as the imaging pictures also.
Okay, sir. Sir, and another question, in case of adults, when they have clinically chikungunya-like pictures, they start them on short cord probably. So how good it is in modifying the course of the illness? Is there any relation whether these patients will not grow into chronicity?
I think the adult ID physicians would be able to contribute to that.
Okay. All right, then I think it's we have overshot the time by half an hour. Thank you so much. More than 200 still watching this program. Thank you very much, all the organizers. If there are any final comments from the panelists, Dr. Tripathi ma'am, Dr. Tandale, thank you so much for joining us.
Actually,
Thank you so much. You first.
Yes, Tandale sir.
Yeah, actually, just thinking about keeping in mind chikungunya always when outbreaks are happening. So whenever patients are presenting with fever or rash,
And the chat be turned on.
so we should keep that as a profile to check for chikungunya possibility. And as presented, then have some altered manifestations, but definitely physician can pick up that he is likely to be chikungunya. So let us identify patients and manage them better and test whenever it is possible and with well on interval. Thank you.
Thank you so much. So,
Thank you.
all pediatricians, if you're seeing unusual cases with chikungunya, you have NIV support, and this has been a great discussion. Thank you, all the panelists, for this enriching webinar. Thank you.
Thank you, Dr. Dhanya Dharmapalan from Team Maharashtra IIP. Also, thanks to Dr. Balasai Tamle, Dr. Anuradha Tripathi ma'am, our own Dr. Pramod Kulkarni, Dr. Atul Kulkarni, and Dr. Vijay Vishwanathan, our own pediatric dermatologist. You all have taken lot of efforts in last 1 to 2 days to prepare for all this. In spite of the busy schedules at NIV, Dr. Tandale and Dr. Anuradha, ma'am, you took out the timing, and almost 1.5 hours you have deliberated, and you have actively participated in the concerns of all the pediatricians in this ongoing outbreaks of chikungunya. And what to say about Dr. Dhanya Dharmapalan? She initiated this in last 4-5 days only, and she took all the efforts. She just told me, and we just have
We want to
taken
put our details
this
in the
to
chat.
on Maha-IP, and all the pediatricians, our own scientific convener, Dr. Bhavesh Mithia, Dr. Anna Saib, Dr. Akhilesh, Dr. Nathu sir, and all they have, Dr. Vishnu and Deepa ma'am, and all the pediatricians who have actively participated in this session, and also many PG students and many of the seniors from across India. All the IIP members, Dr. Ramakrishna Paramhans was there from Andhra Pradesh, Rajahmundry, and Dr. Srinivasan sir was from Chennai, or he might be in USA at this time. He is a very senior academician and teacher of teachers. He also contributed to this discussion. So I thank each one of you for your active contribution in the success of this webinar, and all the pediatricians will be getting a lot of inputs out of this discussion, and the post session link will be shared to all of you, so you the one who have missed, they can watch later. So thank you one and all, and good night. Yes.
Thank you.